So I'm going to take the pro part of persistent postoperative cognitive dysfunction, and I'm going to try to convince you it's a reality, which I do believe it is. So it was an easy way for me to come here. This is the article that got us all really started thinking. This is over 60 years ago. Dr. Bedford was an internist at Oxford, and he had heard people come in or their families saying, my mother or my father or I haven't been the same since surgery. So he looked at the records of nearly 1,200 of his patients that he considered elderly. And if you notice his definition, it's somebody who's 50 years or older. So I think we have a lot of elderly people in this audience. And he had 1,200 that had had operations under general anesthesia. He looked at the medical records, he talked to the patients or their families, and he concluded that mental deterioration occurred in about 10% of the patients. And this was a case series, and when you look, it was something from just little memory loss to dementia. So he didn't have any definition of what was going on. He concluded, though, that the cognitive declines were probably related to anesthetic agents and hypotension. And I think we have followed along and sought that for years. And even for a while, we would tell elderly people they were too old to have surgery. And fortunately, we have gone beyond that now because we realize sometimes not having surgery the outcome is worse than just having the surgery and hoping for the best or doing good care. So when we look at this problem, I think we really need to focus on the level of evidence. Since the late 1970s, when Dr. Sackett and the Canadians first introduced this idea, we've talked about levels of evidence. And we have different levels of evidence ranging from 1A, which is systematic reviews of randomized controlled trials, all the way down to 5, expert opinion. If you go back to the Bedford study, you could see that he's probably a level 4, so not very high quality of evidence, but certainly did present a problem that needed to be evaluated. So really the standard for levels of evidence is now what we see in the Cochrane reviews. And if you go and look at the Cochrane Handbook for how you're supposed to do a systematic review, you'll find that they say that it should be a systematic assessment of all randomized clinical trials that are similar in nature. And that's really an important thing. You can only take good randomized clinical trials and compare them if they're similar in nature. And they even state that inclusion of trials that are poorly designed may compromise accuracy. And not all published and unpublished literature is of satisfactory methodological rigor. So I think our next speaker is going to talk about a pyramid of evidence, and he's going to cite that there are systematic reviews saying that POCD does not exist. But if you go back and look at the trials he's reporting, these do not reach the level that you would see included in a Cochrane review. I think none of these trials would ever be acceptable for a Cochrane review. They're small studies, they include cohort studies, some are just case control studies. There's one inclusion, if you look at the Scott study, he included studies with a sample size greater than 1. So that means it had to have at least 2 patients in it. So when you go back and look at what I think the next speaker is going to talk about is systematic reviews, you're going to realize that what he's talking about is very flawed. And if you look even closer, you're going to see that these reviews evaluated declines in neuropsychological test scores in many different ways. They did not use a standardized definition of POCD like we heard our last speaker talk about. They didn't use the same type of cognitive testing, and they did repeated testing, and when you do that, you get practice effects. People learn before they come back at 3 months or a year, and the people that come back often are the ones that are doing better, and they have learned, and so they'll do better when they repeat the tests, even unless you use parallel forms. In the last lecture, we heard that many people didn't come back for testing, and this is a real serious problem. When you look at these studies, 20 to 30% of the people often do not return for late testing. And it's well known in the psychological literature that people who think they're not doing well often will not return. So the subset of people that don't return are the ones we really need to be following to see if persistent cognitive decline really exists. You can also see mask individual cognitive decline when you analyze group data. And if you look at the reviews that are supposedly level 1 evidence, you'll see that even the reviewers in these studies say, and these are quotes, "Conclusions are limited by scant and heterogeneous data and low individual study quality." And another one says, "Research suffers from a large number of underpowered studies and a range of other methodological difficulties." Even Dr. Avedon, in his review, says, "One of the major difficulties in studying cognitive decline relates to imprecise definitions." So these are, at best, levels 3 and 4 quality studies. They are not level 1 that could be included in a high quality review like a Cochrane review. Now, I also want to talk about the problems you see when you look at group comparisons instead of individual comparisons like was done in the ISPOC 1 and 2 study, where they actually used an individual as his own control and followed him pre and post. If you go and you look at people who come, you're going to see, and this is from Dr. Newman, who did a very nice review of this back in 1995. You can see that about 75% of people may have improvement on their tests because of the learning effect from taking these tests over repeated decline. And then you may have a group of 25% that actually did deteriorate. But when you combine the group data, it's going to look like there's no change because the improved people are going to water out the results from the people who had deterioration. So when you're looking at these studies, you also have to make sure that they're following an individual over time and not just the group data. So what makes clinical research relevant? Well, certainly it's not changes in test scores, statistical changes in test scores, although that's one of the markers we use in our studies. I was fortunate to get a master's in clinical research when I was at the University of Florida through some NIH-funded grant that I received. And one of the things that I walked away was whenever you do research, you need to ask the question, so what? The person that you're seeing back who's coming for surgery doesn't care if he had a 20% change in his test scores. What he wants to know is this going to affect my survival? Am I going to have more complications? Does it increase cost? Is it going to affect my lifestyle when I leave the hospital? And these are the outcomes we need to be looking at, not changes in statistical test scores. And we've spoken quite a bit, the last speaker talked a lot about the ISPOC 1 study, and I also used the same methodology and did a study. And so we now have 2 large prospective studies using recommended methodologies. These were cohort studies, so they're level 2 evidence, where we had pre and post-op testing, we had age-matched control groups. These 2 studies used the identical neuropsychological tests and tested at the same time, and they used the identical definition of POCD, relative change of 2 standard deviations from baseline, which I will point out is a very strict definition. A drop of 2 standard deviations from your baseline is pretty significant change. And we talked about the ISPOC 1 study, and they found that at 1 week after surgery, 26% of the study patients who were 60 years or older had significant decline. And at 3 months after surgery, you can see here, compared to controls, you had 10% of the patients who had significant cognitive decline. Now, this came out in 1998, nearly 20 years ago. That was the year I went to the University of Florida and started there and met Dr. J.S. Gravenstein, who was the senior author on the ISPOC 1 paper. And he got me interested and involved with the ISPOC group, and I started getting involved in this. But I will say Dr. Steinmetz actually published several years ago, long-term consequences of POCD in the elders that had been in the ISPOC 1 and 2 studies that were Danish subjects. And he looked at the cognitive testing at 1 week and 3 months after surgery, and then was able to go to administrative databases to look at mortality, involvement in the labor market, and social transfer payments. And he found that POCD at 3 months was associated with increased mortality and the risk of leaving the workforce prematurely. And certainly those are outcomes that matter, not statistical changes. And the other thing I want to point out is if you look at, let's look at survival. You can see that these are people that had POCD at 3 months after surgery. The dotted line are those that showed significant decline. You can see that by 4 and 6 and 8 years out, quite a few of these people had died. So if he had gone back and looked and retested people at that time, you might not see a significant change, persistent POCD, because the people who suffered the problem had the most severe form of cognitive decline. They were dead. So, and I've always wondered how to deal with dead people. I mean, that is, like the ultimate cognitive decline. So when I was at University of Florida working with Dr. Gravenstein, I decided I was always a skeptic about this research, and he wanted me to do something with it, but I didn't feel like I could go on unless I convinced myself this was a real problem. So I was fortunate in that I was working with the ISPOC 2 group at that time, so I had access to the methodology, and I designed a study using the same tests, same methodology, testing at the same time point. But you never want to just do a total replication, so I included younger people, those less than 60, and had young, middle-aged, and elderly people. But other than that, I was able to learn from the ISPOC 1 group and very happy to use their methodology. So what I found was very similar in the end result. If you look at the early test time, and the white are young, the blue are middle, the green are elderly people, I expected when I designed this study that young people would not have significant cognitive decline at 1 week after surgery or at hospital discharge. But you can see it didn't matter if you were young, middle-aged, or elderly. Everybody had a significant amount, above 30% to 40% of the people had cognitive decline. And when I looked at this, I found out that we tested the people at hospital discharge or if they were in the hospital 1 week after surgery. Well, we don't keep people in the hospital even if they're having major surgery for a week. We send them out at 3 to 4 days after surgery. So these people are all on pain pills, they're all sleep deprived, they're recovering from major surgery. So this early test period I don't even include in studies anymore because I don't know that we're looking at cognition, we're looking at the results of major surgery. But when I went out 3 months later, I replicated what they had found in the ISPOC 1 study, and I had about 12% of my patients had significant cognitive decline compared to the controls, age-matched controls. Slightly higher, but I had a much lower dropout rate than they did in the ISPOC 1 study because we drove around the state of Florida to test these people. We went to their homes, and we had a very low dropout rate. And this is where I was right then asking the question, so what? And we were very busy enrolling 1,200 subjects. So I said, well, are they alive or dead? That was about all we could do. And so we called up people to find out if they were alive. We went to death registry. We called family. And this represents the people that survived to take the 3 months test. We found that if you had POCD at hospital discharge, you were more likely to die in the first 3 months after surgery. But of the people who took the testing at 1 week and 3 months after surgery, if you didn't have POCD at either of those times, you only had a 2% incidence of dying. If you had it at hospital discharge but not at 3 months, or at 3 months but not at hospital discharge, you also had a pretty low incidence, less than 4% incidence of dying. But if you had persistent POCD at hospital discharge and you still had it at 3 months, your rate of dying was 11% in the first year after surgery. And so these are people that would never be tested again at 5 years after surgery because they already died. But the POCD at 3 months is an important outcome because it predicts who's going to die or have an early death. So dementia, there's been a good study that Dr. Everett from Australia has put out recently in Anesthesiology. The prevalence of dementia 7.5 years after coronary artery bypass surgery. She had a prospective longitudinal study where she tested people at 3 months and 1 year after surgery. And in this study, there were 326 patients, 55 years or older, who had open heart surgery. And she had a control group of 51 subjects. So she tested them in the first year, and then she came back and tested them at 7.5 years after surgery. And she had a clinical psychiatrist diagnose dementia in these patients that came back at 7.5 years after surgery on the basis of the clinical dementia rating scale, the cognitive test data, and activities of daily living. And this looks at the survival. And you can see the top line are the patients who did not have POCD at 1 year after surgery. That red line below is the patients who had POCD at 1 year after surgery. So you can see there's a significant number of these people die before you even get to 7.5 years to reevaluate them. So we're losing a lot of the people who had POCD. Then when you look at the prevalence, this is survival, okay. Then when you looked at the prevalence of dementia after surgery, you find that many of the people also who had POCD at 1 year also were diagnosed as having dementia 7.5 years after surgery. So it's a little different than what Dr. Steinmetz said, but I think there is still a question as to whether the POCD will predict dementia later in life. We certainly know that POCD at 1 year after surgery or 3 months after surgery will predict whether you're going to survive or not. This is a study that was published recently looking at optimized anesthesia to reduce POCD in older patients. But they also compared these patients to controls. They did baseline and 1 year testing. There were no baseline difference in the tests between the controls and the people who had surgery. They either had major abdominal or orthopedic surgery under general anesthesia. This was not cardiac surgery. And then they looked at the test scores at 1 year, and they looked to see what had happened to these patients or controls in the first year. And they diagnosed them as having what they called mild POCD, or age-associated cognitive decline. If you had a 1 standard deviation decline at 1 year on your test scores, they said you had age-associated cognitive decline, and that's a diagnosis that is made in many elderly people as they age. Then they looked at moderate POCD, which they said was a decline in test scores of 1.5 standard deviation, and they defined severe POCD, as the ISPOC studies had done, as a decline of 2 standard deviations. And you can see compared to controls, the patients had an increased level of cognitive decline in all of these areas. In the age-associated cognitive decline, in moderate cognitive decline, 1.5 standard deviations, and they found about 11% of patients had severe POCD at 1 year after surgery. So this 11%, 10, 11% number keeps coming out in older people after surgery. This is a study that Dr. Liu recently published looking at a prospective randomized trial evaluating the progression of mild cognitive impairment after surgery. And I think this is really where we need to be going with our studies. All the early studies, we and I did it myself, the ISPOC studies, we excluded anybody who we thought had significant cognitive decline. We did MMSE testing where 0 to 30 is normal, and if you're less than 24, you have cognitive decline. So we were not following the patients that had cognitive decline, which I think is something we really need to do, because patients don't just come in for surgery with an MMSE 24 or higher. We're doing many patients in the operating room who have cognitive decline prior to surgery. So all of these 180 people had a diagnosis of amnestic mild cognitive impairment. She randomized them to 3 different anesthetic groups, and she also had a control group of 60 subjects with amnestic mild cognitive impairment. So she matched her controls to have the same cognitive impairment as her study group. And she reevaluated them at 2 years after surgery. And at 2 years after surgery, she found the rate of progression of amnestic mild cognitive impairment to progressive mild cognitive impairment in patients who had surgery, and it was especially higher in people who had sevoflurane anesthesia, the inhalation compared to the IV anesthetic technique. She found 55% of the patients with sevoflurane had progressed from amnestic to progressive MCI, so had progressed, compared to only 29% in the control group. So this suggests, this study, that general anesthesia with sevoflurane and inhalation anesthetic may cause MCI progression. She did not find any difference in the progression to full Alzheimer's disease among the groups and compared with the controls. There's 2 studies that have come out of China, and these are database studies where there's been a retrospective review of claims data done by this Dr. Chin. This is a study that was prior to 2000, and she's also done a review after 2000, which has very similar results. She found 5,345 subjects greater than 50 years with a new diagnosis of dementia. And she compared them to a control group of over 21,000 patients without dementia. And they were matched, this is a database study, for age, gender, and index data. And she found the risk of dementia was higher in patients exposed to surgery under general anesthesia. But she also found an increased risk of dementia in patients who had diabetes, hypertension, stroke, or atherosclerosis prior to surgery. So these are not necessarily people that were totally healthy prior to surgery. And I think a lot of us are starting to feel like it's a patient who walks in, whatever their pre-op cognitive status or their pre-op comorbidities are, that this is going to be much more predictive than the type of surgery they have. So what are my take-home thoughts on this? I agree that persistent POCD is rare, but I think it exists. And I think it's even more of a problem to just say, oh, POCD doesn't exist, when you look at the number of people who die in the first year or the first several years after surgery. Would they die if they didn't have the surgery and develop this cognitive problem? I haven't spoken much about the etiology of POCD, but I personally don't think it's linked to the anesthetic or to the surgery. I think it's linked to the preoperative cognitive status and the comorbidities that the patient has, and that there are some people who walk into surgery who are set up for developing this problem, and that there are probably subgroups of patients at risk, people with genetic vulnerability to Alzheimer's disease, or those with significant preoperative cognitive impairment. And the last study that found hypertension, atherosclerosis, diabetes, all being linked to dementia later on, well, these are all diseases that cause white matter changes in the brain. So these people probably all walk in with impaired brains, and then whatever happens to them, whether it's the inflammatory response or what we're doing to them, they end up having more cognitive impairment later on. I've pointed out that most studies exclude people with an MMSE less than 24. So we're not including in the ISPOC 1 and 2 studies. We didn't, in my study, we didn't include the people that were at the highest risk of POCD. We need to do studies that include these people. We can, stratify them prior to surgery, but they need to be looked at too. And persistent POCD is probably going to be the highest in patients with an MMSE less than 24. That is if they even survive for us to test them later on. So we need a lot more evidence. It'd be nice to have level 1 randomized clinical trials. It may be hard to do because people won't want to be randomized to a surgery or no surgery group. So what we need is large cohort trials monitoring outcomes, not statistical changes in test scores. And we need to look at the individuals, not group data. We need real outcomes, disability, morbidity, and mortality. So I think there's a lot more work to do. I've been involved in this work since 1998, and I'll be moving on to do more fun things later on. So there's a lot more work for people to be doing in the future, and it still needs to be done. So I want to thank you for your attention, and I'll be glad to take questions on the panel.